All right, listen up. We're on a high-speed mission to master the colon for your board exams. We're targeting the 3 critical areas: vascular, inflammatory, and neoplastic diseases. Let's get straight to it. Okay, mission briefing is live. We're breaking down what I call the 3 primary colon disasters. You absolutely have to get these down cold because they are guaranteed to show up on your exams. First up, vascular. We're talking acute mesenteric ischemia. This is a massive surgical emergency. The patient is screaming in agony, but when you check their abdomen, it's soft. There's a classic phrase for this you need to burn into your memory. And there it is, pain out of proportion to exam. If you see that, your brain should be screaming mesenteric ischemia. Okay, next, inflammatory. Think diverticulitis, the classic left-sided appendicitis. It's all about that fever and localized pain, and there's a very specific rule for how you diagnose this. Here's the golden rule, the one thing you can't forget. You never, ever perform an urgent scope in acute diverticulitis. Why? Because that bowel wall is inflamed and fragile, and you risk perforating it. It's a disaster. So the CT scan is absolutely mandatory. Now let's hit our third target, neoplastic disease, aka cancer, where the screening rules have totally changed. Pay attention, because this is a huge update. 45 is the new 50. Colon cancer screening for average-risk people now starts at age 45. This is a game changer designed to catch those polyps way earlier. But hold on, before we dig deeper, we have to hit the brakes for a second. Okay, just so we're all clear, this content is designed purely for educational purposes, for your international medical exams. This is not, I repeat, not medical advice. For any real-world clinical decisions, you always consult official guidelines and, of course, a specialist. Right, back to the action. Let's run a simulation. You've got 2 patients. Patient A, 70 years old, has atrial fibrillation and is hit with sudden severe belly pain, but their abdomen feels soft. Patient B, 60 years old, with classic left lower quadrant pain and a fever. Now, a keen intern runs up and says, let's urgently scope them both. Is that the right call? Is that the correct protocol? No way. Absolutely not. Let's break down the intern's error. Patient A, with that AFib history and pain out of proportion, that is a textbook setup for acute mesenteric ischemia. An embolus likely shot down to the gut. The only correct next move is a CT angiography to find that clot. Wasting time on a colonoscopy could literally lead to a dead bowel. And as for patient B, their symptoms are screaming diverticulitis. And we already know the #1 rule here. An acute phase colonoscopy is strictly forbidden. The risk of perforation is just way too high. You could turn a manageable problem into a surgical catastrophe. So what's the correct playbook? It's the cool down protocol. Step 1, diagnose with a CT scan. Step 2, treat with antibiotics to calm everything down. Step 3, you wait. Let the inflammation subside for 6 to 8 weeks. And only then, step 4, do you perform a colonoscopy to rule out anything else. Now, speaking of traps, let's talk about the biggest one in the new screening guidelines. Listen up, because this is a classic board exam trap. The number 50. This is the old data, the outdated protocol. If you see an exam question and your mind jumps to 50, that's a fail. It's obsolete. The new standard, the number you need to have locked and loaded, is 45. That's the starting line for colon cancer screening. In your average risk patients, 45. But you know it's never that simple, right? The boards love to add complexity. So what about family history? What happens when a patient's first-degree relative, we're talking mom, dad, sibling, or child, had colon cancer? Well, that changes the entire algorithm. Here's the logic gate you have to know. For a first-degree relative, you start screening at age 40, or 10 years before the age their relative was diagnosed. And here's the key part, whichever comes first. So look at the example. If their dad was diagnosed at 46, you subtract 10 years. That gives you 36. 36 is earlier than 40, so you start screening at 36. Got it? Good. Let's lock all this in. All right, let's run a rapid-fire drill. You see pain out of proportion to exam. What's the diagnosis? Boom! Acute mesenteric ischemia, likely an SMA embolus. Next. What about left lower quadrant pain plus a fever? What is it? Diverticulitis. Instantly. Okay, so what's the test you're ordering?
The absolute best test in the acute setting for diverticulitis is
CT scan. And what do you not do? A colonoscopy. Good. Moving on to screening.
screening for an average risk patient. What's the starting age?
45, not 50. 45. Final question. What's the rule for a patient with a first-degree relative with colon cancer?
You start at age 40 or 10 years before the relative's diagnosis, whichever is earlier. Excellent. With that, the core logic for the colon is seal. Mission accomplished. You have mastered the colon's high-yield disasters. But your training isn't over. Your next target has been assigned, the liver and its lethal shunts. Prepare for the next module. Dismissed.